You're all in the hot seats. Okay, so Thomas. Well, you got this.
Well, there seems to be a general theme that all this software stuff can only go so far. Thinking of what Carla just said, you're looking for a very faint shade or difference in appearance. So I would argue it would be much better if you could use software in combination with, we sort of mentioned that, in combination with improved detection methods. You look at different wavelengths, you put an amplifier in, whatever, so that you get a stronger signal, which is much more easier to distinguish between good and bad.
Yeah. Yeah, I mean, that's very important. I'm sorry I jumped in, because I think a lot of whenever we present these technologies, people want a silver bullet for everything. So, well, it doesn't do everything. Well, it doesn't have to. I mean, all problems need multiple solutions at different layers. And when we're talking about improving somebody's life, somebody's health, childhood, cancer, you know, moving that, doing that percentage 1% or 2% makes a huge difference. And as such, you should always look at technologies as integrative with humans and working with them, because we don't even touch this human, and that's what Bob was also talking, the human-machine interface, which is, we don't know a lot about this. This is the black box, and it's very important in any of these uses. Yeah.
Steve, you're nodding there.
Yeah. I think it's a really important point, and I think there are two things that are worth mentioning. One is, as Thomas quite rightly said, you need to take as much multimodal, multifaceted data to give an indication. And luckily, a lot of machine learning processes and other traditional processes allow that to happen quite effectively. But I think it also comes back to a point that I very briefly touched on in my talk, and that not all machine learning is the same. There are many different types of machine learning, and it's really understanding which type of machine learning is best for the problem and the data that you have. We've heard about deep learning, the more fashionable type of machine learning at the moment, but there are others. So the type we use is a lot lighter weight, and that gives you the ability to understand a lot more easily how the input data has been used to arrive at the classification, to the extent where you have a mathematical description of the classifier in terms of the input data. Now, that doesn't scale very well, and it's not very good for all applications, but what's important is you can start to really understand how the data is being used to arrive at the classification, which I think is touching on what you're saying, Todd.
Yeah, I'd just like to second that. As I mentioned, the machine learning algorithm we use, supervised kernel PCA, is one of these lightweight methods where you can actually understand what's happening. It's not, neural nets tend to be more black boxes. They're much more powerful, so you got to pick the right tool for the right job. But you should always, I think, you should always start with the simplest one and only go to more advanced ones if you need it.
Now, let me say the simplest one didn't work for CAD systems.
Yeah.
That's why we're deep learning.
It's certainly appropriate.
Yes, sorry, at the back.
Thank you very much for the presentation. My question to Lina, first of all, definitely brilliant presentation. I was wondering, like, if we consider using this technology, digital technology, to the kids for their mental well-being, on the contrary, we are thinking to reduce their use of using the digital technology and making them like more human beings, more socially engaged. So how would you make this, like, the adjustment? Thank you.
It's a question that is something that we always come up against. You know, we're telling our kids off, do not play so much on your computer or a game, and then you present technology to be therapeutic. So I think technology is a tool, isn't it? And we can use it to our benefit or to our detriment. So I think it is being able to harness the good power of technology by using this sort of digital. For example, someone with social anxiety, we say that you can use this mixed reality system to teach children how to be more sociable. But the technology is only one part of it. What it does is it bridges the isolation of the child who's completely inward-looking, completely socially anxious, and then allows them to rehearse this into a safe environment, which is the technology. But then the next step within this wider treatment protocol is to go out there and remember how you did it in a safe environment, the mixed reality, and then rehearse that in the real world. So using technology in a blended model where it is just a stepping stone to they go out in the world and function and live their lives as they want to. Thank you.
I can leap in here because I can. So all of you, control. So I think all of you face, maybe Miles less, but maybe Miles into the future, are going to face the issue that you're transmitting sensitive data about, very sensitive data about people over open platforms initially. So mobile phones and things that can be intercepted. And the consequences for intercepting these data sets for you, for Carla, for Bob, are significant in terms of, I think we had this question before for health insurance and other issues. What are you doing? What are you doing about this? How do you cope with this idea that you're transmitting this very sensitive data across the internet and you don't want to lose it? Go, Steve.
Well, so certainly from a very practical point of view, I think on my slide I showed that we've done studies in medical centres worldwide, and that was very important for a number of reasons. One of the things we decided first off was to use a secure platform. So we used Google Drive because the university has an arrangement with Google, so we understand where the data is. But importantly, we encrypted it at point of collection. So we encrypted it and then transmitted it in an encrypted form and then decrypted it at the other end. So I think that's a very, very straightforward technical answer to your question. And the question is a lot deeper than that. But I think there are certainly some fundamental practical approaches you can do to limit that. But that doesn't answer all of the concerns that you're raising in your question, certainly.
Well, my challenge has been I work in the clinic, so it's less off because it's a closed system. But the system, that means that there's many safeguards in the sense of HIPAA and other things. So what we do is basically anonymize the things, or even we went to run some of these studies, we invented people, which was a big problem because we had to invent the whole system. There are challenges, but I think what is very important is that you do, as Bob mentioned, that you really take care that it's only for health and that it is really, that there's layers upon layers of protection for the people in ways of anonymizing, in ways of not, that will protect people from getting this data being misused. And it is, as we've seen, it is crucial to think of that as well as science. And I think as scientists, we get a lot, to get into these systems, we have to jump a lot of hoops to do that. And it's not as easy, and it's actually quite well protected if you look at it.
Yeah, I would just add that I think at the low level, encryption can do a lot if you use the technologies correctly. We encrypt it. The data is encrypted as it's written to the phone. It's encrypted in transmission. It's encrypted at rest on the server. It's only decrypted when needed. And that's important. And anonymization is great for research studies. If you're actually treating patients, you can't obviously know who they are. I think the deeper question is actually, once you have all these data, making sure you only use them for the appropriate purposes. That's because as you accumulate more and more data, it becomes more and more tempting for a company to monetize it in some other way. And that's, I think, really crucial that we keep this distinction between healthcare companies that don't do that, and they will never do that, and other companies that, if you agree to give them your data, they can do what they want. And that's an important distinction.
Yeah, so as I think you can imagine working in the NHS, especially with children, my problem is the opposite, too much of a protection. You cannot really get anything shared, and that's really the opposite problem that we have. So one of the solutions, a bit more roundabout way, is something that they do in less developed countries where they do not have this massive infrastructure to share data, and it is you make the end user the custodian of their own data. So nothing is really shared across. The person has their own digital recording or their own access to the game, and they download things and they have things, and then they share it as and if and when. And the only thing we can do is educate the children and the parents to be custodians of their own data and then share appropriately as they want.
Miles, I know you mostly in vitro. Have you ever run across this, that it's hard to get access to patient recordings, or that you feel that there are issues there because you're accessing personal health information?
Personally, no. I mean, we readily and regularly check model performance against real EEG, MEG data from patients with epilepsies. But whenever we get that information, it's always anonymized. So we have no idea who the person is. We know which hospital they've seen because that's our point of contact. Every other piece of personal information, metadata, is gone. We just have a raw EEG trace, or set of raw EEG trace.
Any other? Yes.
Just on that last point, I think the danger, particularly in the US, less so here, of these is that there is the practice of direct-to-consumer marketing of drugs, for example, which is a big pressure. And of course, if you've got digital monitoring of patients over time, or people who aren't patients but could be patients, even if it's healthcare organisations, there's a much closer link with companies who are trying to sell either drugs or devices, and that could be used as, oh, you can see your things a bit here. You should go see your doctor about this and ask for this drug, and that's quite a common thing in the States. If we do it through these digital platforms, it could actually bypass what's going on and could become quite potentially dangerous, but also very costly.
Want to respond to that? Just nod.
I think it's a great point, yeah.
Yeah.
It's something that we need to be cautious about and be aware of. Yeah.
Any other questions? Oh, sorry, Karen. You'll need a microphone at the front.
Thank you. I wanted to ask about the nature of evidence, really. In the NHS and in the National Institute for Clinical Excellence, we have a fairly traditional model of what good evidence is, and it's essentially based on standard drug therapeutic interventions, and it's around randomised trials and meta-analysis and economic evaluation. I wondered if the technologies that you're using, whether they're diagnostic or therapeutic, or the technologies that you're aiming to use in the future, whether they present any challenges to this traditional model of evidence.
Well, I can certainly speak. So I mentioned we undertaken a health economic assessment prior to marketing the devices. We're now in discussions with the Academic Health Science Network to evaluate the outcome of having introduced those devices into clinic. So certainly, I think the real motivation is selling the devices. So actually getting them adopted by the NHS is very demanding, and without that type of evidence, I think you're going to have a really big job convincing anybody to buy them. So I think it's part of the natural process. You need to have that evidence to get people interested.
I just wanted to comment. When I worked in the States, it was very different. You had an idea, you could pitch it, and people would kind of would adopt it, and it would be by individual hospitals, and good practice kind of follows. NHS is very different because it is a state system. And then you basically, what I found that the system to bringing it to market, even though it's safer and there's a lot of safeguards, the problem is it is very slow and very demanding. Because not only do you have to show that you are actually making a difference, you have to now interact with patients. Has the patient done this? Even though you might not have interaction with patients, you're just using their data. And you have to show cost effectiveness. And for any product like at least mine, which is really new, to bring it, I can't do it by myself. You have to build, a whole team of people has to do it. So before you might see the stuff that I've done, it might be 10 years. And that is really hard. And that's the thing that I think is problematic. While there are safeguards, it really stifles new research, new things, because it is a huge operation to do. And I think that is problematic. That while safeguarding, it stifles a lot of really great research that has potential, because it's a not one-man show, it's a whole team to do that, and that's really hard.
Yeah, I was going to point out it cuts both ways. I mean, you want evidence to show something works. The example of ketamine for depression is a case where the evidence just kind of evolved organically. The drug was already agreed to be safe. It's actually one of the safest anesthetics. That's why it's still used for that. But there's a whole, it's a complex set of issues. One is the patent ran out on ketamine, so no drug company is interested in actually using ketamine to prove, get it approved for depression. Janssen has just kind of sidestepped that by deriving a slightly different version of it that they could patent. But it just shows it's a complex situation. You want evidence, you want safety. Safety obviously is a non-starter. You have to have that first. But then I do think you have to be careful not to overburden innovation.
I have one last question, and it's Miles, because Miles brought this up, and you mentioned that you'd had disappointing interactions with companies occasionally, where you'd go in, it would be very enthusiastic to start with, and then it sort of peters out. And do you have a recipe? What was the secret sauce that got this going in the end? Was there one thing?
I think it's that initial communication step. Mm-hmm. So where we've formed links with companies at a distance, so through email or through third parties, those are the ones that have folded. Mm-hmm. The ones where you meet somebody face to face, maybe beer is involved. Mm-hmm. It seems to be regularly when these things do work. I think there's just that additional level of honesty. Well, you're offering me that, but can you really do that? And then you in return say, well, it would be great if we could hook up because you have X, Y, and Z resource, and they can turn around and say, yes, we do, or they can be honest and say, yes, we do, but I'm not sure that, we are prepared to share that with you, which is where most of the issues have come from before. It's getting access to what you need to do the science to provide the company with what they need to develop that range of drugs. And the classic killer is that one where, you find something good, you relate it to their lead compound, and then they get very interested and they take that lead compound away from you and say, if you're going to do any more on this, then you have this other one, which is almost identical in terms of the chemistry, but actually when you get down to it, it doesn't work.
Just in case.
Yeah, that's happened a few times.
All right, thank you. It's lunchtime, so I think we can thank all our speakers again. That was fantastic.